I prayed for this, don't forget that. Knelt beside textbooks and burnt coffee with cows smoking on my tongue, wishing for a drop that meant something. This job, this uniform, this sacred grind. Now I wake up, again, on a station couch that smells like bleach and burnout, head foggy from the ghost of a nap that barely counted, boots still laced, radio still whispering, and the tone's always ready to bite. Dispatch is a lullaby now, one that doesn't soothe, but sings me into motion anyway. Every address, a rerun, every overdose, a deja vu, every code called a monotone. I've been American dreaming through 24s, turned 36, turned 60-hour shifts that still can't pay the rent. I have a badge of cash in a bank account that laughs at me behind my back. 2 jobs, 3 uniforms, a forced side gig on the weekends. If no one gets shot, crashes, bleeds out, or burns. They say it's noble work. They say thank you for your service. And they say we support our first responders. Right after voting against a contract that would have cost a raise or a third truck. I should rest. I should. But the pager rings like guilt and sleep feels wasteful when overtime's available. So I pack my trauma into Tupperware, label it for later, and show up again. Tired, wired, ready, but buried. I used to have friends. Used to. But they stopped texting back when I started answering with excuses. On shift, picked up an extra, crashed after 4 calls back to back. And when I show up now, I'm the one who forgot how to sit still. How to small talk, how to be someone who isn't scanning exits, and calculating impressions per minute from across the room. American dreaming, that's what they called it. A career with a purpose, a calling, a pension if you make it that far. I dreamed of being someone who saves lives, and now I count the ones I couldn't. The ones we almost reached in time, the ones who screamed, the ones who whispered, the ones who just stared at that pile of police. Some of them haunt me, and others I don't even remember. There have been so many. I get home, finally, and try to be human again. But the dishes are dirty and the silence is loud, and I forgot how to talk to the person who used to call this place home. They say I've changed, and they say I'm distant. I say just tired, but they don't get it. No one does unless they sat in a seat at 3 a.m. telling a mother her child isn't coming back. No one does unless they've had to smile through bloodshot eyes because strangers said you're a hero while your kitchen bounced. Sometimes I meditate between tones, try to breathe between one heartbreak and the next, but even peace sounds like silence now. There's something in me that can't stop going. Even when I crash into motion, to another call, into another chance to prove I'm still good at this. Still worthy of this job that I've been paying for. I'm still American dreaming, but it's different now. Less of a vision, more of a chase that fog and complex. I still want this, don't forget that. But God, I didn't know it would cost so much. Didn't know that dreaming were tactical hands and bleed into every corner of who I used to be. Didn't know that saving lives might just ruin my own. But I'll keep showing up, because somewhere in the static of the blood, the dream is still there. Faint and fragile, but there. So now I want to ask you guys, by show of hands, how many of you are tired today? All right, now put your hands. How many of you are tired in a way that sleep can't fix? Yeah. So what we do attracts people who are willing to suffer for others. That's part of what makes this work so meaningful, but it's also part of what makes this work dangerous. What I'm going to talk about today is burnout, and I'm going to talk about how you can be absolutely exceptional at your job and still be deeply unwell. In this field, we celebrate exhaustion, right? We reward self-neglect. We call emotional injury professionalism. One time I had a partner who fell asleep at the wheel. Not metaphorically, literally fell asleep at the wheel. We were driving back from a call in the middle of the night. They drifted across the center line, hit the rumble strip, snapped awake, corrected, and then they laughed and said, man, I should probably get some more coffee. We didn't stop the truck. We didn't call the supervisor. We didn't document anything. And we just kept going because that's what's normal. But that's not actually normal physiology. It's occupational exhaustion being reframed as toughness. You've probably heard conversations like this. Somebody says, I worked 96 hours this week. How many of you guys have pulled that? 96 hours a week. Someone else says, that's nothing, I'm on my 8th shift this pay period. Somebody else says, I haven't had a real day off in 2 weeks. And then everybody laughs, or nods, or maybe they feel quietly inadequate because they aren't suffering that much. In many emergency systems, self-neglect isn't just accepted, it is socially rewarded. These lines, I haven't slept, I haven't eaten, oh, I'll be fine. We call these badges of honor in this field. These statements get applause in emergency medicine. They should actually probably get a little bit of concern. So we don't talk about this stuff enough. We talk about cardiac arrest survival rates. We talk about trauma systems, pediatric systems. We talk about our response times, especially at night. But we don't talk about what this job is doing to the people who keep showing up to do it. Burnout providers still show up. They show up every single day. They still treat patients. They may even perform very well until they don't. There was a provider that I know who stepped off a truck after a bad call, went into the bathroom at the station, locked the door, sat on the floor and cried. They were in there for maybe only 5 minutes. Then they stood up, washed their face, fixed their uniform, walked back out, and took the next call like nothing had happened. Burnout doesn't always look like collapse. Sometimes it looks like an incredible performance at an incredible cost. So we're going to take emotion out of this for just a minute. Because burnout isn't just a feeling, it is measurable, it is predictable, and it is studied. It's not weakness, it is physiology. And it's not personal failure, it's an occupational exposure. So, the WHO burnout dimensions. Emotional exhaustion is usually the first dimension that providers are going to notice. It's not simply being tired after a shift or feeling overwhelmed after one bad call. It is cumulative depletion. It's still functioning, but feels like you're running on fumes. I know I've been there a lot. Depersonalization is often vastly misunderstood. It's not being a bad person. It's not caring. It's not intentional cruelty. It is psychological distancing, and it is especially dangerous in this field. Patients, with depersonalization, patients become tasks. They become a check on a checklist instead of humans that we're treating. And when every patient becomes a task, we lose one of the most important protective factors in this work, which is meaning. Reduced sense of personal accomplishment is often quieter but deeply impactful. How many of you guys have some kind of advanced certification, or you just level up in your provider care and you're like, oh my gosh, yes, this is an amazing thing, and somebody says, oh, you're just, raise your hands. For me, I've been told, oh, you're just a critical care paramedic. Or, you know, you have your critical care and I really admire that, but that's what kind of digs into you, right? So providers can begin to feel ineffective, replaceable, and disconnected from the purpose that brought them to this job in the first place. They probably still get good outcomes on patients. They're probably still respected by their peers, and they function technically well. But internally, these providers feel hollow, disengaged, and unfulfilled. Burnout doesn't just make providers tired. It makes them question whether their work or they themselves even matter. Burnout doesn't mean these providers don't care. It doesn't mean that you don't care. Sometimes it means that you cared too hard for too long without any kind of relief. If burnout were just about personality or toughness, we wouldn't see the same patterns across agencies, across states, and across countries. But when burnout was studied, we're finding these same patterns over and over and over again. That's because emergency clinicians and healthcare providers are exposed to a unique combination of risk factors. Emergency medicine is fundamentally misaligned with the human circadian rhythm. I tell people all the time, I don't have a regular sleep pattern anymore working 24-hour shifts. Providers routinely experience 24-plus hour shifts, rotating schedules, night work, and interrupted sleep cycles. This job often asks us to perform high-stakes cognitive work at the exact time that our brain is least capable of doing it. Fatigue doesn't just make providers uncomfortable, it makes them vulnerable. Clinicians experience physical assaults, weapon threats, unpredictable patient behavior, unsafe scenes, and chronic hypervigilance. This creates persistent threat perception. How many of you guys position yourselves in the corner of the room when you're like out to eat at a restaurant? You position yourself where you can see the door. Show of hands. Yeah. It creates nervous system sensitization and emotional guarding. When providers never fully feel safe at work, their nervous systems never fully stand down because the anticipation of violence itself is a stressor. Moral injury occurs when providers cannot provide the care that they believe the patient deserves, are forced to operate in broken systems, and feel complicit in suboptimal outcomes. And I know for a lot of us on the streets, that's vastly dictated by patient care protocols and guidelines. Burnout is not always about doing too much. Sometimes it's about not being allowed to do enough. Chronic understaffing. How many of you guys work at an understaffed agency or hospital or wherever? Because I know I do. Chronic understaffing creates increased workload, fewer recovery periods, mandatory overtime, and increased cognitive load. It can also lead to providers feeling trapped, indispensable, and unable to step away. When systems depend on provider sacrifice to function, that burnout is going to become inevitable. As emergency medical providers, whether you're in hospital or in hospital, we operate under time pressure. We always have these time metrics that we're supposed to follow, right? So we have time pressure, performance metrics, public expectations, litigation risks, and life or death decision-making environments. Providers have to rapidly assess incomplete information, tolerate a lot of uncertainty, manage emotional families, and manage system flow. Most people experience high stress occasionally, but those of us in this room, and those of us who are in this job that aren't in this room, experience it repeatedly, and sometimes it's for their entire careers. The human brain was designed to experience 1 to 3 traumatic events in its lifetime. We might see twice that shift. None of these exposures guarantee burnout, but together they can create the perfect storm for it. Burnout is not surprising. The surprising thing about it is how long providers can last before it really rears its head. It often feels sudden, but the reality is that it's usually the result of long-term exposure. So the problem is that it rarely announces itself. Emergency providers are known for dark humor. We use it sometimes as a crutch to protect us, an armor or shield, right? But sometimes that armor becomes so thick that nothing really gets through anymore. One of the earliest warning signs that providers describe is numbness. Not calm, not resilience, not professionalism, numbness. Providers notice that feeling after an intense call, a lack of emotional reaction to suffering, reduced empathy, and the inability to feel joy or relief. When providers say, "I just don't feel anything anymore," that's not toughness, that's injury. Burned out providers often experience frustration with minor inconveniences. They might snap at their partner or patients. They have intolerance for delays or uncertainty, and anger that feels disproportionate to the situation that they're in. This may surprise providers who saw themselves as someone that's patient and calm and adaptable. Burnout doesn't always make people sad. Sometimes it makes them sharp. Irritability is often a signal of depleted emotional regulation capacity, not actual personality change. Providers may begin to assume worst intentions when view patients as burdens, feel contempt for system or community, and disengage from meaning. Cynicism can feel protective, but over time, it can disconnect providers from the purpose that brought them into this work. Providers might start feeling emotionally distant from their role. There was a time in my career where I'd wake up in the morning and I would be so anxious about having to go to work and not going to work so bad that I would have to puke before I could start getting ready for the day. They might feel disconnected from mission, or they might even be unsure whether they're still doing this job. They're doing all of this while still performing well. Some providers might experience sudden emotional flooding. So that's the sobbing breakdowns that are unexpected, feeling overwhelmed by routine calls like a basic lip assist, anxiety about going back to work. These emotional changes are not character flaws, they are signals. And they are signals that the nervous system has been under sustained pressure for too long. One of the most concerning aspects of burnout isn't just how it feels emotionally, but it actually changes how we think. Emergency medicine clinicians make hundreds of micro decisions per shift. Do I use this size IV or this size IV? Do I put them on 2 liters of oxygen or 4 liters of oxygen? Or do I let it ride because they're a COPD patient and that might be their normal? Do I take them to this hospital or this hospital? Is this blood pressure too low or is this blood pressure too high? Do I need to do something about that? Do I put them on a 4 liter or do I go ahead and get a full 12? Do I give them this kind of pain medicine or this kind of pain medicine or this kind of pain medicine? Do I let somebody ride with me even though it's not a pediatric patient who requires a little cardiac? Do I want Taco Bell for dinner? Micro decisions that we have to make. We make repeated high-stakes decisions and decisions with incomplete information. How many of you guys have had a treat patient? No medical history, no history of present illness or history of injury that you can figure out because your patient is not able to tell you what's going on. And you have to make a decision on how to treat them, right? High-stakes decisions and decisions with complete information. Providers may notice that they start choosing the good enough option. Like, oh, it's a stroke patient, but a 20 gauge is good enough because I don't feel like having to start an 18. Or I don't feel like having to look for a vein that's worthy of an 18 instead of a 20. Decision fatigue does not mean incompetence in this field. It means sustained cognitive load. Burnout plus sleep loss plus excessive stress hormone exposure can impair working memory, short-term recall, and task sequencing. Providers may experience forgetting whether they completed an intervention, they may have difficulty recalling protocols, and they may even have trouble remembering routine tasks, like to maintain C-spine on a trauma patient when it's a multi-system trauma. Many providers describe this feeling like their brain just isn't as sharp as it used to be, or brain fog. Burnout impairs sustained attention. So providers may notice zoning out during handoff, difficulty following radio traffic, needing information repeated multiple times, and even increased distractibility. So burnout doesn't just affect how providers feel, it affects how they think, how they process information, and how they make decisions. And in emergency medicine, thinking clearly is one of our most important safety tools. The burnout doesn't just stay inside someone's head. Over time, it starts to show up in how they move through the world. Providers experiencing burnout often begin to withdraw. This may look like eating alone instead of with the crews, avoiding conversations with the station, declining after-shift social plans, and emotionally checking out during downtime. Sometimes this is subtle. Sometimes it's they play it off as I'm just tired or I'm having a bad day, right? It's not really a dramatic avoidance, just gradual disengagement. These providers are still physically present, but they're not really there with you. Isolation can serve as emotional protection, energy conservation, and avoidance of difficult conversations. But over time, it reduces peer support, emotional processing, and protective social connection. Isolation is both a symptom and an amplifier of burnout. Burnout providers may begin using alcohol, nicotine, sleep aids, stimulants, and prescription medications more frequently, not necessarily as like a recreational thing or an abuse thing, but for regular more frequent, like post-shift drinks with the guys, or needing something to sleep every single time you lay down to sleep because you just can't turn off your brain, or using caffeine or stimulants regularly. I know it's one of my big prejudice. I drink a lot of energy drinks per shift. But substance escalation often reflects unmet psychological needs. Burnout can also alter risk perception and impulse control. Providers may begin driving faster than normal, cutting corners clinically, deviating from protocols, and taking unnecessary safety risks. This may reflect cognitive fatigue, emotional disengagement, and decreased self-preservation. When providers feel worn down, their margin for safety narrows. Behavior change is often the first visible sign and the most ignored sign of burnout, because emergency medicine culture reframes it as being salty, being burned out but still good to go, or just tired. And we often normalize this behavior change, and we normalize it as a badge of honor. Behavior change is not only a wellness issue, but it can influence teamwork, clinical vigilance, and operational safety. For those of you guys who work in a partner setting or in a team setting, so it should be pretty much everybody in here, have you guys ever noticed these changes and not known what to do? Or have you noticed these changes in a partner and now you're starting to think about them? Or you've noticed these changes in yourself and now you're starting to worry about that? So there's a provider that I know that almost pushed the wrong medication on call. They caught it last second. Nobody else knew. They laughed it off and said that they were just tired. But what they didn't say was that they hadn't slept more than 4 hours a night in weeks. And that wasn't just a near miss, it was a warning. Burnout rarely begins with a catastrophic failure. It begins with little subtle shifts, subtle performance drift. It can look like forgetting routine steps, slower task completion, increased reliance on memory instead of checklisting, and even reduced attention to detail. The provider is still capable, still experienced, and still trusted, but something is starting to slip. Burned out providers may delay charting, write minimum narratives, miss required elements, and feel overwhelmed by the amount of paperwork that they have to complete. It's not always laziness. It may reflect cognitive fatigue, reduced motivation, and emotional disengagement. Documentation is usually the first place when we think about operations that burnout shows up, because it is the easiest place to cut corners. Providers experiencing burnout may skip medication double checks. How many of you guys do like a medication cross check before you push any kind of drug? Raise your hands. I can see people nodding. Yeah. So they may skip those medication cross checks. They may bypass certain safety steps and rely heavily on habit. And they may make assumption-based decisions. Burnout can produce delayed scene processing, slower intervention sequencing, and inconsistent patient reassessment, and difficulty multitasking. Burnout doesn't always make providers reckless. Sometimes it just makes them slower in ways that they don't even notice. Providers may argue more with their partners, resist feedback, and feel criticized easily. They may even withdraw from other teamwork. Operationally, that affects communication, trust, and safety. Team performance degrades before individual performance collapses. Providers experiencing burnout may be functioning almost entirely on habit, muscle memory, and routine responses. This is adaptive and short term, but autopilot can carry you through one hard shift, but it can't carry you through a multitude of hard shifts. Operational burnout signals are often the ones that get noticed. By the time performance is drifting, emotional and cognitive strain have usually been present for a long time. Burnout rarely stays burnout, it progresses. Sometimes burnout shows up as a loud person becoming quiet, the safe driver becoming aggressive, or the compassionate provider becoming sarcastic. There's a crew that I know who started stopping for a drink after shift occasionally. At first it was like once or twice a month, and then once a week, and then it was most shifts. It really became the only way they could turn their brains off. But nobody thought of it as a problem. It was just how they survived. Some coping mechanisms slowly become new emergencies for us. So I want you guys to do something a little uncomfy for a moment. I want you to think about someone you work with. Think about someone who's changed in the last year. Maybe they're quieter, more simple, taking more risks, drinking more, not laughing like they used to. I want you guys to ask yourselves, have you ever actually asked them if they're okay? So when we miss these subtle changes, and we often do because of the culture of our jobs, burnout doesn't stay contained, it progresses. It's not just a feeling of being tired for a few months. It reflects sustained exposure to stress without adequate recovery. At first, providers compensate. They push through the fatigue, they use humor, they rely on experience, and they lean heavily on their partners. But over time, emotional resources decline, cognitive efficiency declines, and coping becomes less adaptive. So, step one in this progression is chronic stress exposure. Providers may still feel motivated, committed, and capable, but they begin experiencing sleep disruption, increased irritability, intrusive thoughts, and dread before shift. This is the stage in this burnout progression where intervention is most effective. Stage two is actual burnout. Providers may experience emotional exhaustion, depersonalization, and reduced meaning. This is where behavioral changes begin and operational performance may subtly drift. At this stage, many providers are still functioning well enough that nobody actually intervenes. Stage three is depression and anxiety. Now, providers may experience hopelessness, loss of motivation, and persistent worry, sleep deterioration, and increased substance use. Burnout increases vulnerability to mental health disorders. One important thing to remember, though, is that burnout itself is not a psychiatric disorder, but it is a risk state. And then we hit crisis. Crisis may include severe depression, panic attacks, functional impairment, suicidal ideation, and even abrupt career exit. By the time providers reach crisis mode, the warning signs have been persistent for months to years. This trajectory isn't theoretical. Research across healthcare and first responder populations consistently shows strong associations between burnout and depression, anxiety, substance misuse, and suicide risk. The goal is not to intervene in crisis. The goal is to recognize the trajectory and intervene at the chronic stress level. Shanafelt et al. Shows that large physician workforce studies have shown that burnout significantly increases the likelihood of depressive symptoms and suicidal thoughts. And then Petrie et al. Determined that first responder research shows sustained occupational stress exposure is linked with higher rates of depression, anxiety, and trauma-related symptoms. There's some data that even suggests that burnout contributes to suicidal ideation via hopelessness, loss of meaning, and emotional exhaustion. So burnout isn't just emotional, it's actually neurobiological. Working in this field changes how our systems function. So chronic cortisol. Emergency medicine clinicians experience repeated activation of the stress response system. This involves sympathetic nervous system activation, hypothalamic pituitary adrenal axis activation, and cortisol release. This response is adaptive in the short term because it allows us to respond quickly. It's our fight or flight. Stress hormones are not our enemy; they are survival tools. But the problem in emergency medicine is that the activation of our stress hormones becomes so frequent and prolonged that we may move from acute stress response to chronic stress physiology, the effects of which include emotional exhaustion, impaired emotional regulation, and reduced recovery capacity. Sleep. Who loves their sleep? Because I know I do, right? Do we sleep a lot in this field? Not really, right? So sleep loss. Sleep is one of the most important recovery mechanisms for our brain. But experience fragmented sleep, circadian rhythm disruption, shortened sleep duration, and insomnia related to shift work or intrusive thoughts. Sleep deprivation affects cognitive function, which is going to cause slower reaction times, impaired working memory, and decreased attention. Even one night of poor sleep can impair emotional regulation. So chronic sleep disruption can fundamentally change how we as providers experience stress. Hypervigilance. Emergency clinicians often operate in environments where threat is possible, unpredictability is constant, and rapid response is required. This can lead to persistent hypervigilance. This means we'll find ourselves scanning environments for danger, having difficulty relaxing off shift, having an exaggerated struggle response, and feeling on edge even in our own homes. Our bodies get really, really good at staying ready, but the problem is that they have a really hard time remembering how to feel safe. Chronic stress activation, sleep disruption, and persistent hypervigilance create a nervous system that's always working harder than it was designed to. It can exist as the same physiology that makes you effective in crisis and makes recovery harder afterwards. So, by show of hands, how many of you guys have been off shift but still felt like your body was waiting for the next call or the next patient to come in or the tones to drop? How many of you guys hear your tones in your sleep? Yeah. So like I said, burnout by itself is not a psychiatric diagnosis, but it is an occupational syndrome. When it goes unrecognized or untreated, it can increase vulnerability to more serious mental health conditions. One of the more common mental health conditions associated with burnout is depression. Emotional exhaustion and loss of meaning can gradually turn into persistent low mood, loss of motivation, and feelings of helplessness. Providers may notice difficulty finding enjoyment in work or personal life, decreased motivation, feeling emotionally flat, or feeling disconnected from purpose. But burnout doesn't automatically cause depression, but it can erode the psychological resilience that normally protects us. Emergency clinicians are also exposed to repeated traumatic events over the course of their careers. While most providers don't develop full PTSD, the risk is higher than the general population. We may experience intrusive memories of difficult calls, sleep disturbances, hypervigilance, and emotional attachment. I know, particularly, there was a kiddo that I worked, I guess it's been about 4 years ago now, and there are times still that when I close my eyes, I see his eyes. Because I was up at the head doing every stuff. It's part of the job, right? But it's also something that needs to be talked about. Another pathway we see when burnout progresses is substance misuse, like I've talked about already. Research across healthcare and first responder populations has shown elevated rates of alcohol misuse compared to the general population, particularly among providers experiencing high levels of occupational stress. The most serious thing that we need to talk about is suicide. First responders and healthcare professionals have historically higher suicide risk than the general population. For example, there are national studies of physicians that have found that suicide rates are significantly higher than those of the general population, particularly among female providers. Some reports have suggested that in certain years, especially recently, the number of firefighter and EMS suicide attempts or completed suicides may actually rival the number of line of duty deaths in the United States. Burnout alone does not cause suicide, but it can contribute to the chain of factors that increases that vulnerability. So when we talk about burnout, we're not just talking about job satisfaction, feeling tired. We're talking about something that can gradually affect our emotional health, relationships, decision-making, and in a lot of cases, safety. So if burnout were rare, we could treat it like an unfortunate exception, right? But it isn't rare. These numbers behind me are estimates. Real numbers are likely a whole lot higher because of the lack of reporting. So there's a large workforce study among physicians that have shown that burnout is strongly associated with symptoms of depression and even suicidal ideation. Schoenfeld et al. Found that physicians experiencing burnout were significantly more likely to report depressive symptoms and thoughts of suicide compared to those without. Studies examining first responders have estimated that roughly 20% may experience symptoms consistent with PTSD at some point in their careers, which is several times higher than the general population. Like I said, the last slide, the completed suicides and line of duty deaths are comparable, if not completed suicide and suicide attempts have an upper impact. In this line of work, we're so used to memorializing line of duty deaths, but we whisper about suicide. And then there are studies that show that being awake for 24 hours straight is equivalent to cognitive impairment similar to a 0.1% blood alcohol content, so legally intoxicated. We would never allow an intoxicated provider to come on shift, but we routinely allow those that are profoundly sleep deprived to. So up to this point, we've talked about burnout as something that affects providers personally, but burnout doesn't just stay inside the provider, it can influence patient care. Burnout is not just a provider issue, it is also a patient safety issue. One of the strongest findings across healthcare research is the relationship between burnout and medical care. Let me explain. Burnout affects attention, memory, cognitive processing, and emotional regulation, all of which are essential for safe clinical decision making. Would you guys agree? When providers are cognitively exhausted and burnt out, their margin for error gets a whole lot smaller. There was a large national study published in JAMA, International Medicine, that found that physicians experiencing burnout were significantly more likely to report major medical errors compared to those without. Burnout can affect team communication, which is a major factor in emergency care. I know, so my partner's sitting right down here in front, and I know if we're not communicating well, then our patient isn't getting taken care of well. So if I'm experiencing burnout and I'm not communicating well with her, she doesn't know what I want, or maybe I'm not listening to what she's telling me about the patient, and then that patient suffers because of it. Emergency medicine is fundamentally a team sport, right? We hear that all the time. But when burnout erodes communication, the entire system becomes less safe for the patients that we're trying to take care of. Burnout doesn't usually cause one catastrophic error, but it increases the likelihood of a bunch of small ones. Burnout drives provider turnover as well. It can drive early exiting for the field, early retirement, and reduced workforce stability. When experienced clinicians leave, systems lose that institutional knowledge, staffing shortages worsen, and workload increases for the remaining providers. So burnout doesn't just affect the individual provider who's experiencing it, it can affect the stability of the entire system. So now the real question becomes, what actually helps? What are we going to do about it? It's not what sounds good, it's not what goes well on posters, it's not what looks good in a policy manual, but what's actually going to help providers who are experiencing burnout. Some of these things that we're going to talk about the next couple slides are individual actions, and others are cultural and system changes. To you guys, if you don't take care of yourself, this job is going to take absolutely everything that you're willing to give. The most powerful intervention we have for burnout is also the least glamorous, and that's sleep. I guard my sleep. It took me a long time to realize that I needed to guard my sleep, but now I absolutely guard it. Sleep restores cognitive function, emotional regulation, memory processing, and nervous system balance. Sleep is what the brain does to reset the stress response system. Sorry, I have something in my eye, I can't see. We'll focus. Okay. In this field, we used to wear fatigue like a badge of honor, and I think a lot of us still do, but it's not a badge of honor. It's psychological liability. We're used to saying yes, right? Yes to overtime, yes to extra shifts, yes to covering when someone calls out. I was telling my coworkers earlier this morning, like, they were short yesterday. Yesterday was my normal shift day, but I was on train. And I looked at the schedule and saw that they were short-staffed, and I thought really long and hard about going in last night. I was sitting on my bed and I was like, I should go in and I should help them out. They're short. I know it sucks to be short. We were short the day before. But then I thought about it again and decided that my sleep was more important than a couple extra hours of pay. So chronic overextension leads to exhaustion. It's going to lead to resentment for the job, resentment for your coworkers. Sustainable providers learn when to say yes and when they need to say no. Saying no can include declining additional overtime when you're already exhausted, protecting your scheduled time off, and separating work identity from personal identity. A lot of people outside of healthcare that I know don't know what I do for a living. I recently switched churches, and it wasn't until last weekend, the weekend before, when I was on a retreat, that a lot of my friends realized that I was a paramedic because I was sitting here working on this lecture during some free time. One thing I've personally done to protect my time off is we have active 911, and I turn my notifications off. I clock out and I turn my active off. It's a boundary that I've set that allows me to disconnect from work. And that doesn't mean I don't care about my job, because for those of you in the room who know anything about me, you know that I care about this job. You know that I care about this field. And I can tell you right now, I care way more about this job than this job is ever going to care about me. So setting boundaries doesn't mean that you care less. Boundaries mean that you care enough to still be here years from now. One of the strongest protective factors against burnout progression is social support. So this may include trusted coworkers, peer support teams, mentors, therapy, and your family or friends. Burnout tends to grow in isolation. So talking about burnout is going to interrupt that process. Burnout often disconnects providers from the reason that they entered the field in the first place. I know I've had times where I'm like, what am I still doing here? Why am I still doing this job? This job is so hard, it doesn't give anything back. I see bad call after bad call after bad call after bad call. I am exhausted. But that makes me forget why I started it in the first place, why I fell in love with EMS. Burnout makes you lose your meaning, but meaning is one of the most powerful buffers that we have against burnout. So none of these strategies eliminate stress from this job. This job is always going to be stressful, right? We have human lives in our hands. But they can increase your ability to recover quickly instead of letting it accumulate. So these individual strategies matter. But what if it's not you that's experiencing burnout and it's your coworker or your peer? First thing, best thing is to notice the change. That person who talks a lot that's a little bit quieter. The compassionate provider that's a little bit more simple. Burnout rarely shows up overnight. It does show up in small changes. So one of the best things you can do is ask. Hey, you don't seem like yourself lately. Are you doing okay? Is there anything that you want to talk about? Normalizing support. A lot of people are worried that they're going to say the wrong thing, worried that suggesting going to therapy or seeking help from the peer support team is going to push that person to the edge that maybe they weren't already on. And yeah, maybe you say the wrong thing initially, but what's important is that you notice when you ask. So who in this room is in leadership in some way, shape, or form? Show of hands. Okay. So burnout doesn't entirely be solved at the individual level. We can sleep better, set boundaries, seek peer support. One of the most influential factors we have is controlling our workload distribution. Leadership can help mitigate this by monitoring workload trends, advocating for greater staffing resources, minimizing unnecessary overtime when possible. Leaders can support recovery by protecting scheduled days off. I know, like, there's mandatory trainings that we have to do, right? They can protect psychological safety, so creating a culture where it's safe to say, hey, I need help, or hey, I messed up. And instead of it being a punitive thing or, coming down with immediate corrective action, trying to figure out what's at the root of that. So there's a provider that I know that never called off, picked up overtime, stayed late, took the worst calls without complaint. Their leadership absolutely loved them, their partners trusted them, and their patients were safe with them. Over time, they became quieter, a little more cynical, a little more reckless. Their documentation started to slip, their sleep habits got worse, and alcohol showed up more often. Finally, somebody asked how they were doing, and they said, oh, I'm fine, I'm just tired. They weren't just tired. Sometimes that provider who says, I'm just tired, is sitting in this room next to you, and sometimes they're on the stage lecturing about burnout. There was a period in my career where I was doing everything I was supposed to be doing. I was showing up, I was taking calls, I was teaching classes, working extra shifts, doing the job the way I had been trained to do it. And on the outside, everything looked fine, but internally something had changed. I was so much more tired than sleep could fix. I was more irritable than what I used to be. I was less connected to the work that once had everything to me. And because I was still functioning and doing the job well, it took me a while to actually recognize what was happening inside my own head. But eventually I had to admit something to myself. If I didn't start taking care of my own recovery, this job was going to take more than I was willing to give. It was going to take my life. So there are things that we can do to mitigate this. Find something that's not job related that you love to do. Find somebody that you trust that you can talk to. For me, that's my dad. I'm a huge dad's girl. Anybody that knows me can tell you that. In fact, he was just gone for 2 months and I thought I was going to go crazy. But my dad noticed it in me before I noticed it in myself and he said something, which is what made me look and say, oh, maybe I need to make a change. Sometimes for me, it looks like writing. I write poetry. Sometimes it's about what I see and experience on the job. Sometimes it's about other life happenings. Sometimes I sit on my couch and I watch trash reality TV. Love Island is my favorite. And I'll sit on my couch for a day and just catch up on whatever season. I won't do anything and it allows my brain to turn off. So I want you guys to hear something super clear. If you remember nothing else, remember this. You are non-disposable. As a person or as a provider. Emergency medicine has a way of making people feel like they're replaceable. Because there's always going to be another shift to work. There's always going to be another call waiting. There's always going to be another patient that needs help. And that matters, and it matters a lot. The system is always going to need more people, but your families are always going to need you. So when we talk about burnout, it can start to feel heavy. I know this felt heavy, and I made my presentation dark for a reason. I didn't give you this big introduction of who I was for a reason. And it can feel like once you're in it, there's really no way out, because that's how I felt. But that's not true. There's a provider that I know, a theoretical provider, if you will, that got to the point where they couldn't keep pretending. They were exhausted, angry, detached from patients, and detached from their own life. One day they looked at somebody up and finally said out loud, I'm not okay. And for the first time in a long time, they didn't pick up overtime. They went to therapy. They took real time off. They set boundaries that honestly pissed some people off and made them uncomfortable. Some coworkers didn't understand the boundaries, and some of the leadership wasn't thrilled with the boundaries that they set. But over time, that person started sleeping again. They started laughing again, and they started feeling human again. So what does this mean when you go back to work? Notice the change. I've talked about all of these changes, all of these subtle personality shifts, these cognitive red flags, these all of this stuff. And ask the uncomfortable question, hey, are you actually okay? And be willing to sit and listen. It means not shaming people for taking time off. I encourage you guys earn PTO. You earn your vacation time, you earn your sick days. Use them. Take your PTO. It's not celebrating exhaustion like a medal. It means protecting your sleep. My phone, when I go to bed, it goes on do not disturb. Sometimes I even put it on airplane mode because nobody is going to wake me up in the middle of my sleep. And it means finding support that exists and using those resources early. Do you guys, show of hands, who has a peer support team or a critical incident team or anything like that at your agency? If you don't have that and want to learn how to do it, I encourage you to reach out to an agency that does. So emergency medicine teaches us to be relentless, to keep going, to push through, to show up no matter what. And yeah, those things matter. And they're part of what makes this profession work. But sustainable providers are not ones that never struggle. They're ones that recognize when they're struggling and they do something about it. They speak up earlier, they take a step back when they need to, and they allow themselves to be human in a job that often asks them not to be. And ultimately, this comes down to one uncomfortable truth. And it's that in emergency medicine, we're really, really, really good at saving our patients. We're typically not very good at saving each other. We show up for strangers on their worst day, but sometimes we miss what's happening right next to us. There's an officer that I know who died by suicide in February of last year. I saw him 2 weeks before, and I can tell you I never expected it in a million years. He did not look like the person who was struggling, the person who was thinking about going home and getting his duty weapon and walking to the back of the church that's right next to his house and taking his life underneath the tree. Never would have expected it. We missed it. And that can't keep happening. So maybe in this field, moving forward isn't just about proving how tough we are. Maybe it's about proving how sustainable we can be. So don't give this job more of your life than it deserves. It is important, but it's not worth your life. And I want to be clear about something. If you were someone who was struggling, there is help available. The 988 Suicide and Crisis Lifeline is available 24 hours a day. You can call or text 988 and talk to a real person at any time. You don't have to be in immediate crisis to reach out. Call if you're overwhelmed, if you're not sure what to do, or if you just need someone to talk to. A lot of people use resources like this. Is that a tornado? Okay, cool. Okay. I was like, and if you're worried about somebody else, you can use 988 to reach out and figure out what to do about them as well. So when you go back, who's the one person that you need to check on? Sometimes the hardest part of this job is figuring out who to talk to and who that person can be. And if you don't know who that is, this QR code has all of my contact information. Feel free to scan it, save it, and reach out to me. I'm willing to be that person for you guys because I know what it's like to sit in the middle of burnout and be so desperately alone that you don't know where else to turn. You don't have to navigate it alone. Remember, if you're in immediate crisis, reach out to 988 or to emergency services. From the bottom of my heart, thank you guys for what you do, and thank you for being here today.
Thank you all very much. They're going to be coming around with your